Here's my special secret, though, and that's that I have this split personality. I spend time in the cath lab thinking about hemodynamic physiology, but I also spend time in the PET lab thinking about hemodynamic physiology. And so this case, in a way, is, I was thinking about PET for over 20 years and then the cath lab for over 15 years. So it's this weird view of both of them. And the case I'm going to show you is trying to understand these two ways of looking at things and reconciling them. As you know, the second FFR paper that was ever published was a link between PET measurements of relative coronary flow reserve and invasive measurements. And actually, what Bernard did for this is he got up early, he drove to the patient's house, picked them up, drove them over to one side of Brussels where they did the PET scan. They did the PET scan, got back in his car, drove them over to Ulst in Belgium, where he then put them on the table and made the FFR measurements. So every dot on this graph represents a card trip that Bernard made between Brussels and Ulst. That's where this data comes from. All right, I have two patients, and they kind of look like twins in a way, right? So the man on the left is 51. You can see the LAD. FFR of about 0.6, and on the right-hand side, a 71-year-old woman who has an FFR of about 0.6. And what I'm going to tell you is that I left one of these alone, and I treated one of these. And I'm going to show you why that happens. Let's first meet this gentleman. 51, he exercises vigorously. He is a bit too proactive maybe about his health. He went and convinced his internist to do a calcium score, and that was quite high. And so one test led to another, and before you know it, he ends up in the PET lab. He has a dyslipidemia, and you can see he's on medications and has been treated quite well. His LDL is quite low. His EF is intact. And I've blocked it. He has a subtotal ramus that I'll show you in a moment. But you can see I'm just focusing on the anterior and septal regions. That's the LAD territory. Fantastic flows, right? 3 cc's per minute per gram, a CFR over 3, doing well. But here's his LAD, and I showed you this, right? The PDPA 0.90, he drops down to 0.58, fantastic hyperemic response. We talked about that delta. He's got a lot of flow going down the LAD. Happens to have a small subtotal ramus, but the issue that I'm focusing on here is the LAD. The woman is 71. She has angina when walking on stairs, not just on treadmill stuff, but if she really kind of huffs and puffs up the stairs. Also has a history of coronary calcium, has been treated for her dyslipidemia. When I gave her dipritamol, she had very severe angina, no ST segment changes, but again, look at the flows in her LAD. Quite fantastic, right? 3 cc's per minute per gram, coronary flow reserve over 2, and an intact EF. Here's the LAD, and this is the one that I stented. So there's the LAD ahead of time, 0.61, and then how it looks after PCI. So on the face of it, they kind of look like twins, right? They both have intact EFs. Both the LAD, the FFR is 0.6, the coronary flow reserve is intact. They've got 3 cc's per minute per gram going down those coronaries. Why does the one person have angina and the other person not have angina? And in order to answer that question, we need to think about something we don't think about very often, and it's the subendocardium. And this is one of the graphs that Dr. Gould made back in the late 1970s. And I want to highlight something that maybe we don't think about that often, and that's that when you get a perfusion defect, when you have coronary disease, not all the layers of the heart are equally affected by it. So take a look at that cross-section. The septal wall normally perfused between the subepicardium and subendocardium, very flat perfusion. Look at the lateral wall. You can see the defect, but the defect is really bad in the subendocardium, right? That's the area that shells out. And the reason that the subendocardium suffers the worst is that it is exposed to differential LV pressures during the cardiac cycle. So during diastole, your LV filling pressure is low, all the layers of the heart perfuse. But during systole, your LV pressure goes up to whatever your systolic blood pressure is, and that actually ceases blood flow in your subendocardium. And in fact, as you can see, you can even redistribute blood flow from the subendocardium up to the subepicardium, right? And so because of that, here's the analogy that I like to make. We shouldn't have poverty in the United States. It turns out that we have a GDP, and if you figure out how many millions of people are in the US and you divide it out, every person in the US should have about $70,000 if you do the math. It turns out that people like Mark Zuckerberg have a little bit more than other people. And so the problem isn't income, the problem is distribution, right? Okay, so again, sorry, it's my kind of socialist Canadian bent. So here's what happens in the coronary system, right? You've got 5 liters of cardiac output, crank it up 4-fold with exercise, 5% of your cardiac output goes to your heart, you got 300 grams of myocardium. We shouldn't have ischemia in the heart either. Normally you can have 3 Cs per minute per gram, just like those 2 patients had. The challenge is maldistribution. Trickle-down economics doesn't work in the heart either. And here's some animal data way back from the 1970s by people who understood this. They say methods that measure only total LV blood flow give limited information, because what happens is you have a decrease in the subendocardium, but you can have intact or increased blood flow in the subepicardium. So it's a distribution issue. I'll just show you a few ways you can image this. So this is PET scanning. You can kind of slice the heart into inner and outer layers. It turns out in normal, healthy volunteers, we actually have luxurious perfusion to the subendocardium, right? You have government handouts at rest. And then with stress, you have pretty balanced ratios, right? Things are flat across the subendocardium versus the subepicardium. What happens in the case of pathology is the following. Of course, under baseline conditions, it's all good, right? The ratio is intact. But what happens during hyperemia is the lesions that have high FFRs still have preserved blood flow across the wall, but when you have low FFRs, that's where that ratio starts to drop. What's intriguing when you actually look at the raw scatter plot is that some people can protect their subendocardiums and other patients can't. So take a look at those 2 points that I circled. Both of them have FFRs around 0.6, 0.65. The point in blue, no transmural maldistribution. The point in red, very severe transmural hypernutrition. So let's use that and go back and think about these 2 twins. So if you trace on each one of these patients the subendocardial border and you copy that from rest pictures on top down to stress pictures on the bottom, you can see what's happened. The man on the left, despite having an FFR around 0.6, he has great transmural blood flow and he distributes it equally, right? So he's like Sweden. Everybody gets an equal amount of income. There's no subendocardial ischemia, and that's why he does not have angina. The person on the right maybe lives in the US or something like that. You've got 3 cc's per minute per gram, but you've got maldistribution. Look at that area down at the bottom, that subendocardial shell out. It's a maldistribution problem, and that's why if I could be appropriately circumspect about when we make epicardial measurements, this is not something we can see by sticking pressure wires or flow wires down the epicardial vessels. You can't put the pressure wire down into the subendocardium to figure this out. And that is a fundamental limitation of what we can do with epicardial coronary physiology. Thank you.